And now it's time for the sponsor perspective portion of our program. The Hill's General Manager and Senior Vice President Joe Ruffalo sat down earlier with Dr. Harlan Levine, the President of Health Innovation and Policy at City of Hope. Have a listen.
Harlan, thank you for joining us today. Let's dive right into the topic, cancer care access and equity, breaking barriers to innovation. Why is talking about this issue so important?
Well, hi, Joe. Thanks for having me. We live in a groundbreaking era of innovation in cancer care, but unfortunately, not all patients are benefiting equally. Outcomes for survival vary dramatically. They vary by zip code, and they vary by distance from National Cancer Institute comprehensive cancer centers. These are our leading cancer centers for care and for research. And unfortunately, there's a growing chasm between the innovation that's taking place at these specialty cancer centers and the people who need it most. At City of Hope, a national cancer research and treatment system, we're committed to bridging that gap and expanding optimal care to more patients, more families, and more communities.
Could you tell us more about these gaps and where we're seeing them? What are the barriers separating patients in these breakthroughs, and why do they even exist?
Yeah, with the emergence of precision medicine, everything's improving. Treatments are improving with immune treatments and CAR T cells. There's better diagnostics with genomics. There's better surgical techniques with robotic surgery. And together, these have helped to reduce the mortality rates by 33% since 1991. But these breakthroughs are not equitably distributed, and too many people are being left behind. Take, for example, in California, one study showed that fewer than half the cancer patients were receiving care consistent with national standards. And this is worse for people who are coming from underserved communities. For example, African American men die at twice the rate from prostate cancer, and women, African American women, 40% the rate from breast cancer than their white counterparts. And think of this, if you could take away all the social determinant of health disparities, 1/3 of the deaths could be prevented in young adults between the ages of 25 and 74. So we know that social determinants of health and genetics are drivers of this disparity. But I am concerned that it's the complexity of our health system that is exacerbating these problems. And even some of the things that we do under the banner of value-based care are making things worse.
I've heard the term value-based care thrown around a lot. You just recently wrote a piece for The Hill about this. Can you tell us a little bit more about what this means and how it impacts access to optimal cancer care?
Yes, value-based care should be care that's been designed to achieve the optimal outcome. But unfortunately, every stakeholder has their own definition of optimal outcome. And too often we focus on cost containment, which is the payer perspective. We need to also include the patient perspective. And cancer patients are telling us what they value. They value survival, they value access to expertise, they want a respectful experience, and they want to return to normalcy with as much function as possible. But in the area of access to expertise and survival, let's look at Medicare Advantage plans. These are plans that have more than half the Medicare beneficiaries, and that's about 30 million Americans. Most Medicare Advantage plans use what we call narrow networks to contain cost. And narrow networks mean that you have, as a patient, you have to see providers and hospitals that are in that network. Those narrow networks do work for things like diabetes and back pain and heart disease, where there's an abundance of care, but they do not work for cancer care.
And why is that?
Well, frankly, cancer care is different. The field is no longer just one specialty, but really functions more as multiple subspecialties. With precision medicine, cancer is now understood to be 100 different diseases, each one defined by a DNA blueprint or a specific genetic makeup. And there's new information and new treatment emerging all of the time for all of these cancers. It's really humanly impossible, if you're not a subspecialist, to keep up with all that emerging information. So when we narrow a network that is already stressed to keep up with all the new information, we're actually making the problem worse and outcomes decline. And we know from the data that Medicare beneficiaries are far less likely to access one of these specialty centers or even a center that's accredited by the Commission on Cancer. And this is actually true in commercial plans as well. So if you think about it, this lack of access really hurts the outcomes. Take, for example, Medicare Advantage. Patients who have cancer surgery on their stomach or their liver are 50% more likely to die in the first 30 days. And if you have surgery on your pancreas, you're 100% more likely to die in the first 30 days. And also, these narrow networks don't have oncologists that are experienced in and confident using precision medicine, or they're not trained to deliver some of the newer therapies like CAR T-cell therapy. And they certainly don't have the infrastructure to conduct early phase clinical trials. So patients are less likely to receive these approved therapies, and they're far less likely to enroll in research trials that may offer the best treatment.
That's interesting. Can you tell us more about this research and the impact that narrow networks have on it?
Well, so because of precision medicine and targeted therapy, research trials are no longer shots in the dark and oftentimes include the best chance for cure, particularly for people with advanced cancers. But if people can't access these centers, then they're not getting on the trials, they're not getting a chance to live, and then we as a society aren't innovating and finding the next generation of cures and solutions for patients. Take, for example, lung cancer. 10 years ago, if you had metastatic lung cancer, you averaged 6 to 8 months to live without a clinical trial. But if you were on the right clinical trial, you would be living on average 60 to 80 months, and you could still be alive today. And without having done those trials 10 years ago, we wouldn't have all the life-extending treatments that we have today for lung cancer. And because we know minorities are in more narrow networks, again, they're disadvantaged. We know that African Americans represent 15% of cancer cases in the United States, but they only make up 4 to 6% of patients in clinical trials. So again, narrow networks for cancer are perpetuating unacceptable disparities, and by blocking people from getting into trials, they're slowing the progress in finding cures for the future.
So what are some examples of policy solutions that we could offer that would eliminate these barriers to innovation and improve cancer care and access and equity?
Well, we know that changing policy is really hard, but at City of Hope, we believe it's our obligation to be part of the solution. And we think we have a model for future policy reform. In California, 2 years ago, we started with the California Patient Bill of Rights resolution. It was the first of its kind, and it laid out the rights of every cancer patient upon diagnosis. And then last year, we took on the California Medicaid program. We did that because in many cancer types, patients with Medicaid actually had worse outcomes from people that had no insurance at all. So we helped to enact the California Cancer Care Equity Act, in which we ensure that patients with complex cancer have the right to go to an academic center if their narrow network doesn't have the appropriate level of care to take care of their advanced cancer. And now this year, on a federal level, we're looking to redefine network adequacy. We want to modernize our definition to keep up with all the innovation that's happening in oncology. And to do all of this, to drive all of these changes, City of Hope launched what we call as the Cancer Care is Different Coalition, with multiple stakeholders across the industry to raise awareness that cancer truly is different.
Is there anything else you'd like to share with us today?
Well, I'd just like to say that health plans of today are really ill-designed to keep up with the innovation in cancer, and they lead to disparities because of the barriers that they create. So if there's 2 takeaways I'd like our audience to have, one is that cancer care is different, and 2, we really need to define value thoughtfully, particularly when we talk about value-based care. Truly transforming cancer care requires stakeholders to work together and be open to a new approach and new alignments. One place to start is simply to think about how can community oncologists work better in partnership with academic medical centers. City of Hope actually started a company called Access Hope, where subspecialists and experts from NCI centers work together specifically to support medical oncology take care of their patients in the communities. But if we step back and look at this holistically, I would assert that it makes no sense to focus on cost containment on a system that is already leaving too many people behind. And perhaps we need to change our priorities and first start with solving health equity issues and access issues. And once we have those solved, then we can begin to focus on affordability and value, and this time define value with the patient in the center.
Harlan, thank you so much for your time today, and I'd also like to thank City of Hope for sponsoring today's program.
You're very welcome.